Dr. Choll W here from sunny San Diego, California. Check out this troublesome spine. This is a colleague, actually, a radiology tech that I worked with many years ago up in North County, but he's moved to Arkansas, and he unfortunately has had some trouble with his back and previous surgeries. He had a microdiscectomy with a revision, and he's had all kinds of trouble. He had a spinal fluid leak with a pseudomeningocele, but mostly he has persistent severe spasmodic pain and numbness in the left L5 distribution. And the problem is this 4-5 level disc. If you look really closely at the x-rays, if you look at the difference in the angle of the L4-5 disc space when you bend forward versus bending back, that is like a pizza pie, and that's parallel. That's angular hypermobility in the setting of a patient that has had 2 laminectomies. And it's like an arthritic, micro unstable knee. It will cause lots of pain, and unfortunately he needs a fusion now, but I think that's going to be a great operation for him because he does have angular instability and severe back pain. And my 89-year-old mama had a lumbar fusion when she was 84, and she still plays golf. So a good minimally invasive fusion done in the right circumstance is life-changing in a good way. So I have to do a very careful, meticulous job because I'll probably have to find that spinal fluid leak and repair it if it's still leaking. And I want to realign the spine in a way that opens up the space for the nerves, maintains his lumbar lordosis, because you can see how flat his spine is, all through 2 little incisions and delicate Asian fingers, as well as all the latest and greatest in equipment and computer-assisted navigation. So I'm expecting great things. We're getting started. Step 1, identify the landmarks of the spine using anatomy. Tailbone, coccyx, spinous process, straight line, station at a previous incision. Then I feel the iliac crest right there. And then I follow that down to the posterior superior iliac spine. That's where the butt dimple is. It's the powerful tendon attachments, or the confluence of the tendon attachments, to the gluteus, paraspinals, and obliques. And that's why there's a dimple, because those powerful tendons dive in there and attach all those muscles to the pelvis. So I put a dot as to where I think the center is. Then I use the spinal needle to map out the bone. And I start in the middle and I just walk my way laterally. That's the lateral edge. That's the medial edge. Distally, I still feel good bone. Proximally, I still feel good bone. It may be even better right there. Yes, it is. No, it's not, because proximally there's very little bone. This needle mapping is really important because it's just not enough. And then finally, if you can't feel it because it's so thick, you bring in the C-arm or the O-arm and do it under fluoro, but this feels perfect. Local anesthetic, 5 cc's of 1/4% Marcaine. Even though the patient's asleep, because I believe in the gate theory of pain. Okay, I've mapped out where I think is going to be the best spot, a little stab incision. I'm still not done. Now, another mapping. I twist like a tight ring through the fascia until I feel bone. And same thing, I'm mapping it. Oh, that feels good. Now I've done a couple of things to make this not slide off, because it'll slide off medially or laterally very easily. If it slides off medially, you'll go inside of this SI joint and you may think you're okay, which you probably are, but it's not as stable as bone. If you got laterally, you'll feel really loose because you'll be in soft tissue. And I eventually want to, since I'm doing an L4-5 MIS TLIF, I want this flight to be medial and distal, otherwise it's going to get in my way. You still want to start in the bone 90 degrees, and I have a couple of things. I have my hand on the patient and 3 delicate Asian fingertips on this, and I can feel everything. And it's a titration, until I feel it go in by 1/2 millimeter. Ooh, he's got good bone. Okay, 2 millimeters. And I have such tactile feedback here. If it slides off, I should be able to feel it, just like Helen Keller. Now, as I hit this, I'm going to little by little lean distally immediately without torquing on it, because it's not that hard to break this stem. If I feel it slide off, I stop and start again. You want this to be stable. You're going to rely on navigation, because a lot of the accuracy depends on the stability of this pin. Oh, that feels good. And it sure helps when the patient has good quality bone. And that's it. PSIS pin placed ever so delicately yet confidently. And then I feel that. Oh, that's rock stable. And double check this right here. If you have these teeth not locked into place but perched up like this, and you don't know it, you do the spin, a little bit of vibration, it clicks into place, you get a big shift in the navigation images and you may not notice. And it's probably a very important source of navigation error. Same thing with the balls, same thing with anything loose. Oh, that feels good. And there it is, DuraPro, a reciprocating drill. Instead of spinning, you just rotate slightly back and forth like a cast saw or a craniotomy saw so that it doesn't wind anything up. So that's safer. Not as aggressive, but this is feeling good. Rotating shaver. Feels so good. I feel so safe too. Here's another huge advantage. On a regular burr, when I'm about to get started and somebody has hard bone, this will skip off. But there's absolutely no skipping with this because it's just reciprocal. You lose a little tactile feedback, but it's worth it. And this is really hard bone, so this is going to work great for our osteoporotic patients. Okay, put in some screws now. I created the tract already. Some funky looking pedicle, but that's common. Oh, what a good bite. Can you hold that? Because I may have to go double fisted. Very good bite. You have good bone. And yes, like my mom always said, if you don't cheat every once in a while, you ain't trying hard enough. And this is cheating. Look at that. I don't even know how I put in pedicle screws without navigation back in the day. It's sort of like once you taste honey, you cannot go back to sugar. Oh, likey, long time. That's good. You know what's so great about the DuraPro for this particular case? There's a pseudomeningocele, and I don't want to even get near it right now or start making it leak until I'm ready to work on it. And I'm really working right next to it. Oh, Ari, we're thinking about you. I'm using DuraPro, and I'm loving it. It is so awesome. Keep an eye peeled for a post about it, but I just wanted to say thank you for all that you do. Happy New Year, and hope all is well. Oh my God, this thing is, it looks like my cleaner for my bridge. What do we call this? The Christmas tree with navigation. Oh my goodness, look at that thing back and forth. It's obscene. Okay. Nicely tucked. Man, that 8 degrees is more like 12. Love it. Shot and save. Oh, it's still moving. Good. Don't let me get too greedy, guys. Oh, that's good. He was really unstable. Look how tall that is. It's like an A-lift. Back and forth. Yep, now the bone's not moving. You look at the posterior corner. of the vertebral body. It's not moving. Everything else is moving like a bowel gas. So I've done the inner body reconstruction. You're going to feel so much taller. I released the anterior edge of the L5 nerve root, L4 nerve root, and then I went up above, and the bone, which is basically the facet joint bone, it's called the superior articular process bone. That's gone. And I'm looking right at the lateral aspect of the dural tube surrounded by scar tissue. And you can see, look at that. If I go higher up, that's where the pseudomeningocele is, bone. But I did a Valsalva and there's no leakage at all. So I think the best thing to do is to leave that pseudomeningocele, because if it starts leaking and won't stop, I'll have to completely resect all this tissue, find the leak that I just reopened, and close it, and it may leak again. So it is no way leaking from below or above. And it looks like everything's working and all the neurologic monitoring is stable. So I am feeling good. And I think we just have to connect everything and get you back to living your wonderful life again. Traversing nerve root, coming around to the exiting nerve root. Dorsal recess all the way up to the inferior articular process. There's a sliver of bone. It's floating too. Just above that would be the pseudomeningocele. Oh, I'm not touching that. And I can kind of see where it's swollen right here. There's the dural tube. And I can see where the patch was. Best to leave it. And if it wasn't for this drill right here, and yes, it's very, very expensive. It just goes like this, like a cast saw. I was able to take that bone almost right to the dural tube. If I didn't have this, I would have been very cranky, because peeling gum out of shag carpet is no fun. But oh, I feel good. You're taller, you're stable, and the L5 and L4 nerve roots on this side are just thoroughly free and decompressed. Let me have two small curette one more time. Oh, your surgery went so beautifully. And look at how cute those incisions are. I was able to make 2 paramedian incisions. And I can't wait for you to see the before and after pictures. So we're all hoping for a great result and praying for a speedy recovery. So best wishes.